Good morning, everyone. I'm Katie. Hello. I'm going to be talking to you about pediatric airway emergencies today. Special thanks to the Airway team and the PEM attendings for all their wisdom. I chose to talk about this topic today because it scares me. So learning objectives today, we're going to talk about a case from start to finish, go over physical exam and workup relating to a case. Recognize signs of airway compromise, and then differences in anatomy and airway management in peds compared to the adults that we have more exposure to. So here's the case. You're working in the peds ED. A mother brings in their 2-year-old son after he developed a sudden and onset cough with a wheezing sound that she's describing as like a high-pitched sound when he breathes in. She had left him alone for like just a second playing with his toys, and then when she turned around, he was having this all of a sudden cough and this like high-pitched noise. So there we go. So this is what he looks like though. Cute as a button. Really great vitals, looking okay. Awake, alert. The only really pertinent positive is this noise that she is describing or is saying is wheezing, but what is that noise actually? Of course, that's stridor. So parents likely won't know what this word is, and they might say wheezing, or it might even be triaged as wheezing, but we have to differentiate what that noise actually is. We also have to differentiate what's the difference between inspiratory stridor and expiratory stridor. Does anyone kind of know what that difference is other than when it happens in the respiratory cycle? Caleb? Yeah, awesome, perfect. So inspiratory stridor is above the vocal cords, and expiratory stridor is below, like deeper into the windpipe.
Man, you don't.
So that's an example of inspiratory stridor. Sound real scary. Okay, so what are you worried about with this kid? Totally. That's what I'm worried about too. So that's what we're going to be talking about today is a foreign body aspiration. So commonly happens in kids under the age of 4 and with a slight male predominance. I don't know what that's about. Most children are witnessed to have had a choking event at the time of aspiration. But if they don't, they come in with like cough, dyspnea, stridor, irritability, like this kid kind of. Most foreign bodies are organic, so like a seed, a nut, that kind of thing that might be like dropped laying around. Other foreign bodies can be like coins, bits of crayon, anything really. And that's why it's just really important that like the most important part of this lecture is remembering to do that anticipatory guidance for prevention of choking. Dr. Seeger's shout out does a really good job of this with her dispos of going over prevention of choking as well as other things. Okay, what's the next step for working up this kid? Yeah, that's the next step. Okay, keep going. Okay. I was going for x-ray, but thank you, Kelsey. So I say x-ray and there's an asterisk here. So I'll talk about it later in the presentation, but there's just a caveat to this part of the continuation of the case. After discussing with the PEM attendings, what you might do in like a textbook and algorithm might be different than what you would do in real life, and I'll get to that later. But for now, we're going to follow kind of the textbook algorithm approach. So x-ray. What might you see as being like a flaw of an x-ray is finding a foreign body? Yeah, it has to be radiopaque, otherwise you might not see it. And a lot of things aren't radiopaque. If you don't see, if you suspect a foreign body and you don't see it on x-ray, what would be the next step? Bronch? Yeah. So I did find some researchers that are saying like you could consider a CAT scan because CAT scans are getting really good. And it would save this child from a traumatic experience of getting sedated in the bronch and everything. That being said, the gold standard is still a bronch. And even if like all of your imaging comes back negative, if you have a story that's concerning for a foreign body, you have to do the bronch. Does anyone know of any like secondary findings you might see on an x-ray that would suggest a foreign body, even if you don't see the foreign body itself? Totally. Nice job, Kyle. So there are secondary findings. The hallmark is just like of an aspirated foreign body is like a lung volume that's not changing with the respiratory cycle, and that can present itself as air trapping. So air enters, goes around the foreign body, and then it cannot exit, kind of collapses, and so the air builds up. And so that lung, the one with the foreign body in it, will appear overinflated, hyperlucent, might have a depressed hemidiaphragm. So the example here, the left lung is showing you something that would suggest a foreign body on the left, increased radiolucency, all of that. Does anyone know of any like special types of x-rays that they do for a foreign body workup other than just like the AP? So there's like a suspected foreign body inhalation series. So you can do one where the kid is breathing in and one where they're breathing out, and that might help to determine if there's any differences in the lung volumes. And then the other one is doing a bilateral decubital film. So on the top one, that's like a normal decubital film. As you can see, oh, there we go. The bottom lung looks a little bit smaller in volume compared to the top one. And that's normal because of gravity. But the one below, the x-ray below, you see how the lungs kind of look equal in size. That suggests that there's some air trapping in that bottom lung, and that would suggest that there might be a foreign body in that one. So that's where a decubital film is really helpful too, if you can't actually see the object. One of the PEM attendings also gave a pro tip that if you are not sure if an object that was aspirated is radiopaque or not, if it has like a sibling object, so like if it's like a hair beret and they have another one, you could put that under an x-ray and see if it shows up or not. And that would kind of help you figure out how important it is to go down the foreign body pathway. Okay, back to the case. The nurse alerts you that the child's status is changing. These are the vitals now. The stridor's more noticeable, more constant. They're becoming increasingly hypoxic, look to be in more distress. You've tried some medications to see if it might help, some racemic epi, albuterol, nebs, steroids. Unfortunately, nothing has been helping. What are some things that you might try to improve the oxygenation ventilation in this kid? So don't forget about the PALs that we all studied diligently for the beginning of residency. If you think that this kid is choking, then we have a pathway for that. And this honestly might be a life-saving thing. So for infants, the back blows, chest compressions is a way to try to push that object out. For older kids, the abdominal thrusts. Just remember, like blind sweeping in the mouth is not recommended because you could push it further down and make things worse. And also if you like look in the mouth and you see something, we have tools in the ER that you can use to try to more securely grab it. So like forceps and that sort of thing. All right, you tried those things though, it didn't work. Seems like things are getting worse. What are some things that you're thinking you might need to do next? Yeah, totally. You're thinking that you might need to intubate. There are some things we could try first, like airway adjuncts to see. So why not? You're throwing everything at this kid. You're trying the NPA, OPA, all the things. They're not really doing anything. So you're here. Despite all your efforts, the kid's getting worse. They're becoming more cyanotic. The stridor is constant. You're applying supplemental oxygen, like nasal cannula, high flow, like someone suggested, that's not working. You're doing like BVM, manual ventilation at this point, and it still doesn't seem like it's improving that much, maybe like a little bit. So someone said it earlier. Yeah, that's where we're at. I've never done this. I know some of you have, and I've seen it, and it's impressive. And I was sweaty the whole time watching you. I have like sweaty palms even just thinking about this, which is why it's important for us to talk about it. So, in a situation where a foreign body can't be removed and they're developing respiratory compromise, and you can't bag anymore, if you can bag, that's enough, right? You keep bagging. That's a more secure way of keeping that airway open until you can go to the OR. But if you can't, like the situation, you have to do the intubation. And part of the thought process is that you can push the foreign body more distally. And if you have to, push it into like one of the bronchi, because, you know, shutting off one of the lungs is better than losing both of them. So that's the next step. We get ready to intubate. What's different about a peds intubation? A lot. Do you remember off the top of your head everything about a peds intubation? No, of course not. Why would you? You're a normal person. So, you know, anatomy obviously is like a big difference. Positioning is going to be different. And then like the sizing, the med dosing, all of that complicated, not so complicated, but it feels complicated math. So anatomy, kids have big heads. They have a lot of adipose tissue that could obstruct landmarks. Their larynx is like more anterior. Their cords are slightly slanted, making that like initial visualization kind of weird looking. You know, it's a narrower tube that you're looking in. The epiglottis is super floppy. The tongue is bigger. They may or may not have teeth. If they do have teeth, those teeth might be fragile and easily like bust it off and create another aspiration risk. They also have large stomachs compared to their lungs, so they're more likely to throw up on you. So lots of things to consider. How do you prepare for like tube sizes and medication doses for peds intubations? Nice. Oh wait, first I want to talk about this. So this is just to show like the positioning that you would do, the sniffing position, which like we do for adults too, but it might be some different maneuvers to get the kid into the right position. A towel roll is really good, but also if they're like bigger than 2, sometimes the like neutral head position is useful as well. Okay, and then you might not have ever used a Mac blade or a Miller blade before. What's different about using a Miller blade than the Mac that we typically use for adults? Yeah, what are you doing differently? Yep, exactly. So the Miller, you're like lifting up that whole big floppy epiglottis. That's like what's so useful about using the Miller with peds. And the Mac, you're going in the vallecula and lifting up. So you opt for the Miller, and then sizing. I heard someone say the Braslow, of course. So like there are equations that, you know, you should commit to memory because you're going to be tested on this at some point on the boards. But in the stress of the moment in like a critical situation, relying on an equation that you may or may not remember is probably not the safest thing to do. And we have some memory tools that we can fall back on, which the Braslow. We also have Pedistat, which is great too and correspond with the Braslow tape too. So the colors correspond with our crash cart. So you line the kid up, figure out where they're at on the tape, and then that drawer is the drawer you use. Similarly, it lines up with the Pedistat with the weight. Of note, the way that they are measuring this child, one of the attendings said, an easier way would be to have the 0 line up at the edge of the bed, like the head, and then like pull the kid by their ankle to the edge of the bed so that they like line up with their feet at the end. It's just a little bit easier, whatever. I'm gonna skip over this. So you attempt to intubate. You're using that Miller blade because of that floppy child epiglottis. You attempt to intubate and you can't pass the tube. Your attending attempts and they can't pass the tube. Anesthesia is there at this point and they can't pass the tube. And now when you apply the BVM respirations, there's like no improvement at all. Like they're tanking. What might we do next? So that's this terrible situation that we all hope we're never in. The like classic can't intubate, can't ventilate, and also can't use any of the adjuncts that we tried as well. So if you can't put the tube in, unfortunately, you do have to move on to getting some form of an airway, which is with a crike. Do we do a surgical, like open crike? I mean, like the neck seems really small. I don't know what I'm looking at here. What's different? Yeah, the space isn't big enough. And you do the needle crike. So interestingly, like the literature doesn't have like an age specific cutoff between the needle crike and an open surgical crike in kids. I think it's because like it used to be more like an emphasis on a specific age, but now they're becoming more aware that like maturity of a child and like what you're actually looking at with their anatomy is more important. So it kind of depends is the answer. But that being said, 8. Less
dying position.
Yeah.
So I just this case also we have is like, I mean, just do it. The kid is gonna die at the end. What else you is die or you try something
Yeah.
else. Okay.
Yeah.
I don't want to go down that path.
Yeah, but I think just in terms of you designing your algorithm,
So 8.
you're not gonna be in the mind frame, so.
Yeah. 8. Moving on. So these are the supplies that you're gonna need to use. Apparently there is like a bag of this specific set of stuff in the Pete's crash cart. To be determined, but that's what that was told to me.
Last time also there, like the attending side, the lower dryer on the right side.
Oh, really?
Yeah, that is.
I'll let y'all know. But here's the supply list. You need gloves, something, the chlorhexidine or something to wipe it off. Lidocaine plus minus if you need it to anesthetize the area. And then on the left here, this is the angiocath setup. So you're gonna take the 7.5 ET tube connector piece off of a tube and then use it for this setup, or it might just be in this bag that I said is maybe there. And then you need a 3 milliliter syringe with the plunger taken out, and it has to have a lure lock on the end so that it can twist tightly into the catheter. And then a 14 gauge catheter that is like a over the needle setup that you can also find in the central line kits. It can't have like an auto guard, otherwise it won't work. And then a BVM connected to an oxygen source.
Identify the thyroid movement by sliding the finger down. Thyroid movement there. Finally, stabilize the larynx with your one hand. In your other hand, get a syringe to the skin. Aim 30 to 45 degrees coldly and gently advance the needle until you feel a pop as you pass through the thyroid membrane. Aspirate air to confirm that you are in the airway. Control the needle and advance the cannula into the airway. Remove and safely discard the needle and syringe. Connect your side port ventilation device, the patient, and connect oxygen tubing to the wall and to your device. You can deliver some oxygen to the lungs of the patient by occluding the side port for 1 second and allowing it open for 3 seconds. 0, 1, 0, 1, 2, 3. 0, 1, 0, 1, 2, 3. Please note that this is only a temporizing measure and definitive control of the airway has to be gained as soon as possible.
Okay, one more time to hit it home, or if you can't understand his accent. So you're gonna position the patient, find the cricothyroid membrane, stabilize the trachea with one hand, clean it off, maybe use the anesthesia, cannulate the trachea with the IV catheter, caudally at a 45-degree angle, advance while aspirating until either you hear pop, like what he said. Another way to do it is to fill the syringe with water or lidocaine so that when you aspirate back, you'll see bubbles, which I think is probably the recommended way because the ED is loud, and that way you can actually like have a visual that you're in the right place. Then advance the catheter, remove and discard the needle, attach the syringe, aspirate air again to make sure you're in the right place, attach the ET tube connector adapter, attach to the low pressure oxygen supply, and then secure in place. Honestly, I didn't really find like a good method to do this. Maybe our respiratory colleagues know how to do that, or tape, or just hold it. Like you're gonna be good. You're you're gonna be with this kid until they're in safely in an OR.
Want to highlight something that Katie just said, and that wasn't in the video. You should be aspirating. I don't like the idea of putting it in and then seeing that, because one of the worst things that could happen is you go straight through the trachea. Right?
You
And
may
it's-
not be able to fill up pop if they're really small.
Yeah.
Like very soft and metal.
Yeah. And I think using the fluid is fine, but it's you should get it should easily come back with air. Like you're not going to get that sub-Q and then all of a sudden you should get it with air. But I mean, the kid, as we talked about, the kid's size is going to be variable, so filling is specific. That rating doesn't sound good.
Remember that the membrane is really superficial. So if you're going like really deep.
You're in the wrong place.
Yeah.
Yeah.
If we're up here, you-
The technique, everyone should be comfortable with the color, right? You're going in and
But it is really easy to go like all the way through.
Yeah.
And then you're connecting it to some sort of oxygen source to ventilate. And like they said, it's all a very temporizing measure just to get them from RED in the elevator to the OR to the next step, which is a definitive surgical airway. So hopefully while all of this is happening, someone else has already consulted all of your teams. So surgery, ENT, palm, whoever is going to need to like do the bronch to remove the foreign body, because everything really needs to be happening at the same time.
Point about that as well, is we don't have other people. I would say that when you are going into intubate a kid with a foreign body, you should have called all of them. This is not a situation where it's like, let me see how this goes. Call everybody. So I'm going in the room to intubate this kid. I want whoever's supposed to come and bronch. I want anesthesia. I want those people here. And if they get there and you're done and it's all good,
I literally wrote this to mention after, don't be the captain of a sinking ship. One of my attendings in residency always said that. It's not that we're calling people because we don't know the next steps. We know exactly how bad this could be in the worst case scenario. You want all of them to be there so you can mobilize.
I will say one thing I have heard when we do that, which it is the right thing to do, is that the anesthesia team tries to take over. So support each other so that we can try to do our first attempt at least. Okay, so you have them connected to oxygen, and so you're able to provide some oxygen at this point, but there's an issue. You're oxygenating but not ventilating at this point. So they're becoming hypercarbic due to that lack of ventilation. There's this like apneic oxygenation that's happening. Even if you're doing the like bagging, they're not ventilating themselves. So that's why, has anyone heard of the jet ventilator? So, I mean, it's a cool like idea, in theory, somewhere it might work. But it's, studies demonstrated that if you have like intermittent jets of pressurized oxygen at like 50 PSI, it allows for some oxygenation and ventilation happening. One thing that like you have to consider too, though, is that there's a foreign body doing air trapping. And so if you've ever had like a COPD patient that their chest is like huge and you're trying to resuscitate them, and if you've like pushed down on the chest, you might need to do that for this kid too, to like push out some of the air, to try to improve the capacity for doing some ventilation. I think that what he was just doing is like the ventilation ratio that you should be doing. So like theoretically, maybe if it's not like a partial obstruction, there could be some air coming back out, and that gives like time to allow for that. But for this kid, it's like a full obstruction. I don't know that that's actually going to be doing anything. All right, so we have the crike. You're securing it with your hand. The SATs are improving, thank goodness. Another thing I didn't really emphasize earlier, make sure you have your post-intubation sedation meds going. So they're well sedated at this point too. You already consult everyone and you're on the move to the OR. And after that, they're going to the PICU. So this is where we return to that caveat point. So this, at that top here, if you suspect a foreign body and they're stable, you would go down and get the x-ray as the next thing. After talking to some of the PEM attendings, if the story is suggestive enough of a foreign body and there's any sort of like physical exam finding like Strider that also supports it, leave it alone. Like, don't even like touch the kid or get too close to like upset them and make them cry and potentially like dislodge where that foreign body is and make things worse. And just make plans behind that kid's back about what you're going to be doing next, which is moving, like calling your colleagues and getting a setup in the OR. Because it's kind of like a epiglottitis, like it's a very tenuous airway, and anything might disrupt it and make things worse. So in real life, you might not go down this pathway. Maybe if like it's just the story and everything else looks fine, then in real life you would go down this pathway. But just kind of food for thought with talking with the people who actually know what they're doing. So this is the end of the case. We made it. They made it. Whew. It's a scary scenario, but now hopefully at least you have some tools and have gone through the process that if you know, you're ever in this situation, hopefully not, you'll at least have seen it before. But in this case of an airway compromise where you cannot bag anymore, you do have to go down this pathway of trying to tube and then doing a crike. And also, hopefully this highlights the importance of what Dr. Seegers tries to emphasize every day of doing some of that prevention discussion with patients and their families. And this is my cat.